Recording in progress.
Everybody let in? Okay. Okay, so we'll get started. Thank you to everyone for joining here in person and online for the second session of this year's WHRI Summer Scholar Series event. We begin by acknowledging that WHRI operates on the traditional, ancestral, and unceded territory of the Coast Salish peoples, the Musqueam, Squamish, and Tsleil-Waututh nations. Further, this acknowledgement, gratitude, and respect extends to all the First Nations communities on whose traditional territories the WHRI builds relationships. We continue today in expanding on this year's theme, Sex and Gender-Based Analysis, SGBA+, across the health research pillars. We're thrilled to welcome today Dr. Rachel Ollivier as our speaker. Dr. Ollivier holds a Bachelor of Science in Nursing from UBC Okanagan, PhD in Nursing from Dalhousie University, a primary healthcare nurse practitioner diploma from Queen's University, and is a Menopause Society certified practitioner. Dr. Ollivier works as a full-time nurse practitioner and women's health scientist at BC Women's Hospital and Health Center, providing care to underserved populations in the areas of women's cardiovascular health, complex menopause, and complex gynecology. Dr. Ollivier is the nurse practitioner lead of the new Menopause and Midlife Health Program at BC Women's Hospital and is a clinical assistant professor in the UBC Faculty of Medicine and adjunct professor in UBC School of Nursing. So before we begin, a few technical notes. For in-person attendees, please press the button on your microphone to activate it during the Q&A. For online participants, you can submit your questions via the chat. Olivia Patrick will ensure they are relayed to Dr. Ollivier. We also invite you to the next session on August 13th with the Indigenous Gender-Based Analysis Plus team, who will present on Indigenous Gender-Based Analysis Plus. You can register for this event on the WHRI website, and here's our other contact information. And at the end of this event series, there'll be a evaluation form that'll be circulated to get feedback on the series. So please join me in welcoming Dr. Rachel Ollivier.
Wonderful. Thank you for that lovely introduction, Dr. Yong. And my sincere pleasure to be here with everyone today, both online and in person here in the Clinical Services Building, to discuss some of kind of the emerging data, both clinically and in terms of research related to women's cardiovascular care in Canada. And so with this, it's one that I have the pleasure of presenting, but many of these slides were prepared by the Canadian Women's Heart Health Alliance as well. So just would like to lend credit there, credit where it's due for these wonderful visuals that we'll look at throughout the presentation. I do not have any conflicts of interest to declare, and I'm not being compensated in any way for my presentation today, so we'll get that out of the way. And thank you as well to Dr. Yong for offering a wonderful land acknowledgement before we began today. So my learning objectives today primarily are to first, recognize sex and gender differences in cardiovascular disease, as well as understanding some pregnancy-related or women's health disease-related cardiovascular risks, as well as some of the treatments that are tailored in this population. And it's one where we have, many knowledge gaps that persist, however, do have, changing guidelines within this sphere as well. And lastly, we'll discuss inclusivity and equity in cardiovascular care and research as well, and where we started, where we're going, and future directions as well. So to begin, we know that, of course, cardiovascular disease is the leading cause of premature death for women worldwide. And unfortunately, as you can see from the graph, since 2015, Canada and the United States have been reporting an increase in deaths for women from heart disease. Despite this, we know that women remain understudied, underdiagnosed, undertreated, and under-researched in this area. And so before we delve a little bit deeper, I always like to differentiate between, sex and gender and what we're referring to with this language. So sex refers to biological traits like hormones or chromosomes that classify people as male or female generally. But we know that it's not always binary, as some people have traits that don't necessarily fit into these categories. Gender, on the other hand, is shaped by societal roles and expectations influencing how people, act or go about their day. There's a lot of theory that's been done in this area, but I often turn to Dr. Judith Butler and the theory on gender performativity in this area. But one where we know that gender is a spectrum, and one that it might be maybe defined differently in different cultures or by different individuals. So starting with the facts, as I already said, heart disease is the #1 killer of women worldwide. And it's known that, in fact, every 22 minutes, to be more and more exact, a woman in Canada dies as a result of heart disease. And, when we look at kind of heart disease, for a long time, it was often thought of as, sort of a man's disease. But we now know that, when we think of, if I ask the room, what would you say is a disease that affects women more prominently? People often say, oh, breast cancer. That's one that's often kind of, thought of as being that way. But in fact, we know that 5 times more women die from heart disease than breast cancer. So this is one where we really know that this is an important area to be addressing in care, but that historically has not been. And as well, we know that heart disease rates are rising among women aged 35 to 55. With this, it's one where, awareness and action are critical in overall reducing the impact of heart disease on women. So as I said, this area is under everything, unfortunately, but we're making strides to help bridge this gap. So back in 2018, the Heart and Stroke Foundation released their annual heart report titled Misunderstood. So ms.understood, as you can see on the left there. And this report really put a spotlight on the issues facing women and cardiovascular disease here in Canada. And so for that, again, awareness is building. But despite women making up just over half the population, 2/3 of heart disease clinical research has historically focused on men. This stems from a few things. For, a long time in Canada and around the world, women were actually excluded from medical research studies, both within cardiovascular care and in other areas of medicine, until the early 1990s when, laws around that or guidelines around that changed. And so we're still playing catch up today because those gaps do persist in terms of, not only how we're going about research and methods within that, but also being very intentional about who we're including, who we're excluding, and why. And so this is one where this area in cardiovascular care has been affected, as have many others. So as a result, diagnostic and treatment strategies have been based primarily on data from middle-aged white men, leading to medical decisions for women being made using research that does not account for their needs, for their risk factors, for their physiology, or of course for those gender considerations as well. So this has overall contributed to a lack of understanding of sex-specific symptoms and treatment responses in women, as well as, those effects of how gender and sociocultural factors and contextual pieces may play a role in not only diagnosis and assessment, but in treatment outcomes as well. So touching first on underdiagnosed. So we know that women and their healthcare providers can sometimes be slow to recognize the signs of a heart event, leading to, a missed or overlooked diagnosis. And in fact, it's known that early heart attack signs are missed by up to 78% of women. So this is one where it not only bridges back to awareness, but education, right? Of understanding, okay, what are those differences? And then building awareness around that. Misdiagnosis is especially common in younger women, or those who don't experience the more common symptoms of cardiovascular disease, such as chest pain. We know that chest pain continues to be the most common symptom of heart disease. However, there are nuances to how chest pain is described or experienced. And I'll touch on that a little bit later as well. So healthcare providers, often might focus, based on their education, on other possible causes without first conducting the necessary tests to rule out a heart issue. So we find commonly in practice, and the patients I see in the Women's Heart Health Clinic often have been told that their chest pain might be related to, anxiety or stress. And that's possible, but that's a diagnosis of exclusion in medical terms, meaning that we have to rule out any other physiological factors before we go to diagnosing someone with anxiety-induced or stress-induced chest pain. And in terms of being undertreated, so over the past decade, we've seen mounting evidence of sex disparities in cardiovascular care. And so, what's contributing to this? What's going on here? First, as I mentioned, there are differences in the signs and symptoms of heart disease between men and women. And women may experience symptoms that are more subtle or atypical, making it harder to diagnose. So in terms of chest pain, we often find that, men will report their chest pain as sort of a crushing sensation, an elephant on the chest, whereas women will describe it as more of a discomfort or tightness in the chest or in the middle of the shoulder blades, the scapula. Secondly, there's a lack of awareness about heart disease in women, not only among the general public, but also within the medical community. So this affects all people who are involved in pushing forward that care and that research. And lastly, knowledge gaps exist among healthcare providers, leading to inconsistencies in, how women's cardiovascular health is diagnosed and managed. And so as a result, again, we see that piece coming to not only underdiagnosed, but then affecting the undertreated piece. When it comes to under awareness, despite years of information campaigns, women remain underaware of the significant threat that heart disease poses to their health. And a national survey actually conducted by the Canadian Women's Heart Health Centre revealed substantial gaps in women's understanding of heart disease, and particularly a disconnect between their perceived and actual risk. So for example, 60% of women who are at high risk for heart disease due to medical factors like high blood pressure, diabetes, perceived their risk as low or moderate. And this discrepancy indicates that women's perception of their own risk does not necessarily align with the reality of their heart health status. And as the result, they often experience poor cardiovascular outcomes. So touching more on kind of what are some of those risk factors. So here we'll talk about some of those physiological pieces that we're learning more about, and then move into how understandings of, gender and particularly traditional gender roles play a role in these issues as well. So as we know, the traditional risk factors continue to be an issue for women's heart health. So things like diabetes, high blood pressure, obesity, these are all ones that, most of us are well versed with. But there also exist female-specific risk factors. And so some of these, are more prevalent in women or either unique to women, such as pregnancy complications, early or premature menopause, conditions such as polycystic ovary syndrome, all play a critical role in women's heart health in general. So, and additionally, female predominant risk factors, such as autoimmune diseases and depression, further contribute to these cardiovascular risks as well. So I'll touch on each of these as we go through. And then in terms of gendered factors, such as socioeconomic challenges, caregiving roles, disparities in healthcare access, these also play a significant role. And again, we'll touch more in some detail later on in the presentation. But when we look at this visual here, it's one that, I think illustrates it well of just how much is kind of not only happening in a woman's lifetime, but also is overlapping. So this is just kind of one of, some of the main issues that we see that can affect heart health. But emerging research continues to be, highlight sex-specific risk factors that impact their cardiovascular disease. And so with this, we know, pregnancy, estrogen-based contraceptive use, all these sort of things do have a role to play in women's heart health. But I like this because it just really shows that, that longevity piece as well. So beginning first with, menarche, menstruation, contraception. So age at menarche, menstrual cycle variability, and contraception are important factors in assessing someone's cardiovascular risk. Early or late menarche in particular, so that's the age of someone's first period, and irregular menstrual cycles can impact cardiovascular risk markers and predispose women to arrhythmias. Menstrual cycle variability may also signal some metabolic imbalances that increase cardiovascular risk over time. And again, these associations remain poorly understood, but are now being identified as ways or factors that we should be considering when we're assessing someone's overall risk of cardiovascular disease or cardiovascular events. PCOS is another example I touched on. So this is an endocrine disorder that affects menstrual regularity, hormone levels, and insulin resistance, and is linked to significantly higher risk of cardiovascular disease and stroke. And in fact, women with PCOS are twice as likely to develop these conditions compared to those without PCOS. PCOS, we know, impacts about 4 to 21% of women globally. And interestingly, first-degree relatives of women with PCOS have a 20 to 40% higher chance of developing it themselves. So that's also kind of another interesting piece there. And then when we look more at pregnancy, and particularly hypertensive disorders of pregnancy and association with cardiovascular risk. So pregnancy, essentially can be thought of as a bit of a 9-month stress test, for lack of better words, on a woman's heart. So hypertensive disorders like gestational hypertension, chronic hypertension, preeclampsia, eclampsia, all increase a woman's long-term cardiovascular risk. And by just how much, we have kind of, yet to finalize the numbers, but I'm hearing from experts such as Dr. Beth Abramson, a cardiologist out of Ontario. Oftentimes, in our minds as clinical providers, when we're calculating, it's known, or now being more widely talked about, that risk factors that are present in pregnancy often lead us to double someone's baseline cardiovascular risk when we're doing an assessment using a tool such as Framingham or the ASCVD tool. So these conditions are linked, of course, to accelerated cardiovascular aging, arterial stiffness in particular, and a higher likelihood of developing ischemic heart disease, aortic stenosis, and mitral regurgitation. Premature birth or low birth weight of the baby also can have effects. And these are kind of, again, some key indicators that historically we haven't really been assessing in cardiovascular risk assessments in the clinical setting. However, there is some leading research being led by Dr. Ruby Dev out of the UBC School of Nursing to develop a risk calculator specifically for use in pregnant or postpartum women or birthing people. So again, one that is one we're on the edge on for sure. And then early identification in pregnancy and preventative care in pregnancy. So again, I won't go into too much depth here, but women, as we know, with a history of pregnancy complications should have ongoing care and screenings to reduce their long-term cardiovascular risks. And that's part of where we come in and where we're fortunate to have the Women's Heart Health Clinic for people living in BC. So I see a lot of these patients in my practice after they've given birth to have a discussion about ongoing management and risk reduction. Menopause. So this is one that's getting, a lot of, attention, and it's rightly deserved because it's long been understudied. But we know specifically women who experience early menopause, so that's menopause before the age of 45, or premature menopause, and that's menopause before the age of 40, are at increased risk of cardiovascular disease. And so when women, go through menopause, there is a drop in estrogen, which is a hormone that is, produced by the ovaries largely, and helps with blood vessel elasticity. So we lose that kind of what we call endogenous estrogen, or estrogen produced by the body itself, we know is cardioprotective. And so with those higher levels, typically in the reproductive years, women tend to lose that as they enter the perimenopausal stages and menopausal stages. So that's, again, another piece we know can affect things. And then mental health, as I mentioned, is another one that's now well known as being a cardiovascular risk factor. It's also more prevalent in women than in men. So, for younger women, they're particularly vulnerable to depression following a cardiac diagnosis as well. So this one, the mental health piece is unique in that it's sort of a bit of a chicken and the egg question, because with cardiovascular disease risk, they're very interrelated. If someone is, having symptoms of depression, therefore, perhaps less active, less engaged with their community or with, activities they traditionally enjoy, that can then play a role in increasing cardiovascular disease risk. And then on the other side, when, someone has a cardiac diagnosis, they are at greater risk of developing depression and anxiety as a result of their cardiac disease diagnosis. So again, one that we screen for in the Women's Heart Health Clinic. Cancer treatments also include, increased risk for cardiovascular disease. I won't go into this in too much detail, but just one to note as well. And of course, chronic kidney disease. So this is one of those more traditional ones that we've known has been an issue for a long time. But again, CKD is more prevalent in women than in men. And however, women typically have a slower decline in kidney function, with that being said. So they have, a bit of a different disease course when it comes to one of these traditional risk factors, such as CKD or chronic kidney disease. So in terms of presentation and outcomes, what does this actually look like in clinical practice? So, women and their healthcare providers may sometimes miss the signs of a heart attack, as I mentioned, which can lead to delays in diagnosis as well as treatment. And so for this, it's important to kind of understand how this tends to present. So cardiovascular disease can refer to a myriad of diseases, such as, heart failure, coronary artery disease, previous heart attack, or, issues with ischemia in the heart. But typically, we know that women are more likely to present with 3 or more symptoms in addition to chest pain. And so we're thinking, in clinical practice, oftentimes it's not always necessarily this, obvious crushing chest pain presentation in ER. These symptoms can be nuanced sometimes and often overlap with a lot of other diseases. If someone has nausea or heartburn with a bit of lightheadedness, maybe feeling a bit of fatigue, that could be so many things. So that's part of the issue here is we need to understand how can we have, a routine system of identifying when women present to care, either in the urgent or emergency care setting or in outpatient settings, so that they have workup or diagnosis earlier if there is heart disease going on, and then proper follow-up from there. And then treatment strategies, I'll touch on briefly just because we're not focusing too much. But really the case I wanted to make here is for specialized rehab and care programs. So again, we're very fortunate to have the Women's Heart Health Clinic here in Vancouver led by Dr. Tara Sedlak, and also includes my colleagues, Dr. Natasha Portambela, who's a nurse practitioner, as well as myself. But these are now being recognized as important and critical initiatives to address sex and gender-based disparities in heart and vascular disease outcomes. So again, we've talked about more that diagnosis piece, that assessment piece, but okay, what do we do about it if someone does have a diagnosis? How do we provide meaningful care to women or gender diverse people living with heart disease? So with this, after a heart disease diagnosis, women are 50% more likely to participate in cardiac rehabilitation that's tailored specifically to their needs. So, after a heart disease diagnosis, cardiac rehab often combines exercise, education, healthy lifestyle counseling, psychosocial support. And patients who complete cardiac rehab tend to have better functional outcomes, which I think is no surprise to anybody. However, despite these clear benefits, women are 50%, as I said, less likely than men to participate in cardiac rehabilitation. So why? Lack of physician referral or healthcare provider referral has been shown that this is an issue in terms of, not initially being referred, as well as some physical and psychosocial barriers. Some of those can include fatigue, symptoms of pain, and then the psychosocial challenges like depression or anxiety that I mentioned can make it harder to attend. Time, family, cost, confidence, all these pieces. So we know that, again, when we're looking more at kind of the gender piece of how this plays into everything, women, again, roles absolutely can vary, but often prioritize, their families, their careers, other responsibilities over their own health. And so when it comes for caring for children, caring for spouses, for themselves, for aging parents, perhaps, combined with stress and fatigue, from these roles, it can leave little time or energy for rehab. So, it's often known that this is something where, again, all of us are juggling multiple responsibilities, but how those are prioritized has been shown in terms of, having some differences there in terms of one's gender identity. And then cost of and transportation. So financial concerns can be a barrier as well. So actionable tips. How do we, change care in this sphere? So having, women only or mostly women sessions is one of the key recommendations that came out of the Women's Heart Health Research Alliance research. And this helps to really foster an environment where women feel, comfortable, supported, and understood. And then flexible delivery modes has also been shown as something that can, impact things. So this is, flexibility in where it's delivered. Again, people are often juggling multiple obligations, both in family and professional life. And so providing options like home-based, center-based, or virtual or hybrid delivery is critical. It's been shown in this population. So again, flexibility around that can be very helpful for people. Oops. There we go. So peer support is another piece that's been shown to be important. So this comes in the form of emotional and practical assistance where, people or individuals, shared experiences or conditions, and they can provide support to one another. So this is another piece of, again, feeling understood, which all of us can relate to, right? It can take, many forms: in-person groups, virtual meetings, cafe meetings, informal one-on-one interactions. But this peer support is another piece that they've identified as being important, for not only long-term benefits, but also having healthy coping strategies once they're, perhaps no longer being seen actively in a rehab program, which typically is, 3 to 6 months, and then people are discharged. This provides that ongoing connection. And we've seen a lot of that grow through the Women's Heart Health Alliance as well, of having, patient voices who are, strong advocates and share their experience. to help better shape care as well. So we've been fortunate to have a great network based out of Ontario, and is one that's expanded nationwide now. And so now touching a little bit on not only the data, but some of the research pieces around this as well. So in 2021, the total racialized population in Canada reached nearly 10 million people, making up about 26.5% of the overall population. And this reflects a notable increase, up from 22.3% in 2016. And the largest racialized group in Canada was South Asian origin, followed by Chinese and Black populations. Other groups also contributed to this growing diversity, as shown in this chart. But importantly, each racialized group is nearly evenly split between men and women, with approximately 50% of each group being women. So this demographic shift highlights the increasing diversity in Canada's population, thereby emphasizing the need for inclusive approaches to healthcare policy work and research work. And so going and delving a little bit deeper into this, so South Asian and Black populations, it's well known, face a significantly higher risk of cardiovascular disease compared to Caucasians. And they have increased rates of hypertension, stroke, and atherosclerotic vascular disease. Type 2 diabetes is also more prevalent in these populations, with South Asian women being 3 times more likely to develop diabetes during pregnancy. And this further elevates, of course, their long-term cardiovascular risk. In addition to that, heart attacks and strokes tend to occur much earlier. So on average, 5 to 10 years sooner than in other ethnic groups. East Asians, on the other hand, have a lower incidence of coronary artery disease compared to other groups. However, studies, including one from Ontario actually, indicate a higher prevalence of heart failure. So again, there are very important differences here that, again, we need further understanding on, but this is some of the preliminary data. Another important consideration is the increased risk of non-obstructive coronary artery disease, or MINOCA, in Black populations in particular. So this is one that we often see in the clinic, and I've been fortunate to learn from the expertise of Dr. Tara Sedlak, our medical director and cardiologist, because this is where she specializes, is in that microvascular disease diagnosis and workup. So again, all considerations within what the needs are. And we look at kind of intersectionality. We hear that word kind of used a lot, and it was first coined by Kimberly Crenshaw to describe kind of how these multiple identities intersect when it comes not only to health, but social location, experiences of healthcare systems, et cetera. So when we look at cardiovascular disease risk in women, it's shaped more than by more than just biological sex, of course, right? So these multiple intersecting factors contribute to disparities in outcomes. And it's known that Indigenous women face increased cardiovascular disease risk due to the ongoing effects also of, colonization, which has led to significant social, economic, and political, challenges. So this is one that's important to acknowledge as we, work on, again, that ongoing understanding of how people are affected differently by heart disease. We also know that geography plays an important, impact on cardiovascular risk. So it's known that women living in more rural or remote or unreserved communities may struggle with limited healthcare access, thereby further exacerbating disparities. When there's that lack of access, that impacts all of the, underassessed, underdiagnosed, undertreated. So this is one that we know also plays a role in what people face in terms of getting appropriate care. So more specifically on the geography, we know that, geographical disparities in cardiovascular disease risk mortality determinants are quite considerable. So metropolitan areas experience the lowest amount of cardiovascular disease burden, and then rural, remote, or northern or unreserved women experienced, greatest burden. So when they looked at kind of the research of what were people's experiences in accessing care, they came to no surprise, of course, that rural areas were more impacted by, not only being able to access care, but some of the barriers associated with that, whether that was travel and being away from family and support people that are important to them, being away from community and that support network, financial challenges, travel or logistical challenges. There's so much that plays into this. So again, one that we now have more data on to specifically describe. And then Indigenous populations, experience heart disease and stroke at rates 2 to 3 times higher than non-Indigenous populations. So while cardiovascular disease rates have plateaued or in fact declined among non-Indigenous women, they continue to rise among Indigenous women, highlighting again this growing health disparity that needs urgent attention. These differences are deeply rooted in historical and systemic factors. Colonization has had lasting effects, including the legacy of residential schools, forced foster care placements, exposure to interpersonal or lateral violence, systemic racism and discrimination. All of these are persistent barriers that, again, I think many of us are aware of. But, understanding of, okay, how is this specifically affecting things? And then what can we do about it? What do we do with this information is now the stage that we're in. And then income is another factor that we look at often when we're looking at, say, social determinants of health, is one that is important to look at as well. So, low-income women compared to other income groups of women are, of course, more affected here. So when it comes also to, messaging, it's important to have that be accessible across Canada because of the lack of awareness specifically that can affect multiple groups. And so when we look at this, disparities, yes, the sex piece is kind of one that's been more studied. But we know also, again, gender plays a part in this, not only in terms of when people access care, how they identify their symptoms, but what their experiences of that care are and what sort of follow-up and testing they get as well in the world of cardiology. So, for this, again, just sort of as a bit of a reminder, a slide of how that kind of has an effect on multiple aspects of cardiovascular care and research. So how can you help? What do we do about it? I think there are many people in the room who have ideas and thoughts. But this is something that, we want to look at empowering not only future nurses, but health practitioners, health researchers, physicians, dietitians. This is one that we know is important and is something that's needing more attention. So, of course, one of the most powerful tools we have, no matter if you're in the clinical care setting, in research and advocacy and policy work, your tool is to listen. And so, patients might not always present with the textbook symptoms or be, necessarily advocating for their concerns. They might have had previous experiences of being dismissed elsewhere. That's something I see commonly in my practice. But that doesn't mean they don't matter, right? These experiences matter, whether it's face-to-face with a patient, with a family member, or in conducting research, in having people at the table who have that lived experience and who are able to provide that valuable lens when we're informing policy, healthcare systems, and healthcare delivery itself. So as we know, medicine and research, no matter what area you're in, it's a team effort. It's a collaboration with colleagues, mentors, specialists, learners like we have in the room today to help us navigate these complex cases. So it's one that is something I very much see as a collective effort and one that we all have a part to play in. So with this, we're having, again, I've done a few of these presentations in schools across Canada as well. But coming back to that education piece, this is also, interconnected and multifaceted. But we're highlighting, a critical gap in medical education as well that affects the care of women in terms of cardiovascular disease. So in 2017, there was a survey conducted that exposed these significant gaps to clinicians' awareness and knowledge regarding heart disease in women. And in fact, in the US, they did a survey looking at 44 medical schools and found that 70% of medical faculties reported having no formal curriculum on sex and gender differences in medicine. So this is one that I think is applicable not only to formal curricula in say medical or nursing schools, but also to all health programs, whether that's, health promotion, child health, youth health, women's health. And so these are just some resources to touch on. And through the Women's Heart Health Alliance, again, they have some fantastic visuals, data that's always being updated. So again, something I point you to if you have interest in this area or an interest in learning more. And then also, again, having that resource point in a network of care and researchers, which I'm fortunate to work with, including Dr. Sedlak. Emily Thaberge is another wonderful member of our team. She's currently completing her PhD at UBC. So if you're interested in the research, I'd be happy to connect you with either of those people as well to learn more about what's going on here in Vancouver through the Women's Heart Health Clinic. But, in summary, we know that women experience unique cardiovascular risks that can be related either to diseases that, tend to affect women more or are related to pregnancy or postpartum, as well as some of those lifestyle factors. Symptoms are often overlooked or misunderstood. Equitable care and research is essential. Again, I think we can all get behind all those points. And being an advocate in your work, no matter what that looks like, is again, something that I think we can all do and take away from today. So with that, I say thank you for your attention. Welcome discussion, questions. And again, acknowledge the Canadian Women's Heart Health Alliance for their wonderful slides for use today. Thank you.
Thank you. That was fantastic. Any questions in the room or online. I think we have a hard stop at 150 to 155. Okay.
Questions on the chat yet?
Okay, all right, yeah. Hi.
Okay, so great presentation. Thank you. So, like, as the sex difference in the symptoms, is there any sex difference in like biomarkers that can be identified earlier in males or females, and we can say, okay, it can happen cardiovascular diseases or so in earlier or later in female or male? That kind of study have done or not?
Yeah, no, so thank you. Excellent question. So yeah, when we're looking, if someone say presents to ER, often we're looking for troponin rise if there's any sort of cardiac stress, and because that's one that can be quite specific to the heart. However, it's one where we're, finding out because we'll see patients often with sort of, a trace rise in troponins, which is an enzyme in the blood that can, as I said, indicate cardiac stress. But with, kind of not only the piece of knowing that microvascular dysfunction affects women differently, it's also kind of one where it's emerging about the role of inflammation in the development and presentation of heart disease. So sometimes people will, have the troponin rise that tends to be about the same in both men and women, that, initial kind of blood work that indicates cardiac stress. However, in the follow-up testing that often, comes from that, so whether that's, a cardiac CT, a CT angiogram, an echocardiogram, of course, an ECG, the workup that comes from that, what we often find that, where the gap is, or part of what we know where the gap is, in that follow-up testing, they'll find that people have, completely normal coronary vessels. There's no issues on the echocardiogram. All their diagnostic workup will be completely normal. However, they might be experiencing what's known as MINOCA. So a myocardial infarction in the presence of non-obstructed coronary arteries is what that stands for. So this one, it does require very specialized testing to identify, and it's not one that any ERs, would do routinely. So that's one example where, yes, the initial presentation, there might be similarities there, but then from there, essentially no answers are found, or they don't actually receive that diagnosis because, oh, okay, there's no blockage in the major coronary vessels, which is usually where we look for issues when someone's having a heart attack. And it's found later on that, oh, okay, you actually do have some ischemic tissue from a previous, cardiac event that, was never really treated. So yeah, we do see some of those differences in terms of kind of what that care pathway looks like, and then if and when they find a diagnosis.
Can you tell us more about the menstrual cycle variability in cardiovascular risk?
Yeah, so that is a good one, and one we don't have a lot of information on, really. It's shown, again, that the irregularity can have an effect on kind of future cardiovascular disease, but specific markers within that, what that pattern, how much that pattern can affect things, is not well known and well studied. So excellent question, but yeah, one that would make a good future study for any researchers in the room.
Wondering if any of the prevention steps that you would take for someone who is at higher risk, say someone who, had preeclampsia during pregnancy, is there any gender differences in what you would prescribe to people in terms of prevention, or are those preventative measures, do they work regardless?
Yeah, so in terms of kind of the, piece of, especially after pregnancy, if they've, had these issues during pregnancy that are now largely resolved, really what the, important difference is in how we're assessing someone's risk, which then dictates what sort of treatments or interventions they are, that we implement. So an example of that can be having lower thresholds in terms of someone's, targeted blood pressure, what we consider a healthy blood pressure in someone who's experienced preeclampsia. Same with lipid levels in the blood. There are differences there, in terms of someone's risk. The current Canadian Cardiovascular Society guidelines outline, treatment for dyslipidemia or elevated low-density lipoprotein, which is a harmful lipid in the blood, based on that risk stratification, that risk scoring, and that determines the level of intervention that we then, perform in terms of initiating, say, a medication to lower cholesterol. Where do we want that target for LDL? If we're working on lowering it, how low do we want it? All those are determined directly by someone's calculated risk. And so that's really where, the key gap is that we're generally underestimating the risk in women. And that includes, not accounting for factors in pregnancy where, again, for that example, we should in fact be doubling if they've had issues in pregnancy related to diabetes or gestational hypertension, eclampsia. We should be doubling that calculated risk score based on what we know right now. And those, as we're determining kind of those numbers and those outcomes, that, recommendation will likely either change and or become more formalized. But that's really the piece that is where, we're underdiagnosing and therefore undertreating people who should perhaps be on more aggressive therapies, which can include medications and also, lifestyle factor changes and, dietitian referral and all these things, mental health counseling. So that's part of how we frame our care in the Women's Heart Health Clinic. We have, a cardiologist in Dr. Sedlak, 2 nurse practitioners, and we also have a clinic dietitian and a clinic psychiatrist, Dr. Angela Wong, who see patients in our clinic and understand those risk factors, in more detail. So if someone is requiring some of that mental health support to help with their heart health or with their symptoms of chest pain, or, again, dietitian counseling, which can be sometimes difficult to access, especially for people who are more rural, she offers virtual appointments. So that's kind of, again, all of it comes together. But yeah, excellent question. All right, any last questions?
Yeah. All right. I have a question about so awareness building. So getting the message out to the public that these symptoms and kind of better recognizing women's heart health, symptoms that they could have. But then if you present to your physician or you present to the ER because you're experiencing these symptoms, and then perhaps you're not validated in coming in with those, kind of creates a negative loop where maybe you don't go back and say anything the next time. So just kind of like how that's feeding into each other, and women may not feel like they're going to be heard if they do go in with those symptoms.
Absolutely. And it's a legitimate concern because we know that often people do have those experiences of being dismissed or having, their feelings kind of invalidated or, in fact mocked. It's not always a space where someone is feeling heard and cared for, especially in those more, emergent settings, especially where, the stakes can feel higher and things might be more acute. So no, it's one where the Women's Heart Health Alliance has specifically developed tools on yourheart.ca on how to have those conversations with providers if you do have concerns and are not being heard or don't quite feel like you know how to communicate them. So that's a fantastic resource I often point people to if I'm doing talks such as this for how to navigate those conversations. And that includes also having someone with you if possible. That we know that that's not always possible depending on the context, but a partner or loved one who can help with that advocacy piece or help just provide that support, because again, these conversations can be intimidating, especially, for patients who have those previous experiences of trauma associated with healthcare encounters. We know as well that that's, far more common in people who experience other sociological, disparities, such as racialized folks. So yeah, definitely one that's important to consider. And so we're hopefully working on both ends of not only educating providers to be more aware of that and therefore more willing to listen and do the proper workup, but also on the other side, because we recognize that, yeah, there's gaps on both of those ends. So it's an excellent point, and one that, hopefully as we hear more of those voices, we can develop tools and have a way for people to feel more confident in approaching those conversations. It doesn't always necessarily, mean that it's going to change the outcome. We unfortunately can't control that piece. But that's part of, I think, how we again work together to facilitate that and improve that.
Yeah, following her question, like talking about the awareness, is there any like planning, I don't know, from government or something, that sending reminders or something to the woman that okay, you need to do diagnosis every year or so, that whether you are developing any symptoms or something, like in regular life we may not have any issues, but when we have that reminder, okay, I need to do every year or something, or if I get email or like text from my providers, like health providers, that kind of give me reminder, okay, I have to make an appointment or something so that I can get a diagnosis or something every year or something. Is there any that kind of program happening or no?
Yeah, so none that I'm aware of. It's a great point because I think we could strengthen those ways as well. We now are in a healthcare system where, we have over 700,000 British Columbians without a primary care provider, unfortunately. And a lot of those folks who do have access to a primary care provider, we've, kind of shaped practice to be one where you present with concerns rather than a focus on routine health screening or, annual physicals, which are no longer recommended. So it can be tricky in terms of, knowing how often, should you be talking to your healthcare provider or having that assessment if it's not something you have an immediate, need or symptoms related to, right? So there's no tools in particular for that. There are guidelines that exist for providers on regular health screening. A lot of that is more relevant from a cardiovascular perspective in the population for people over 40, both men and women, just because we know that does tend to be when chronic diseases, generally emerge, and we want to have more screening. So that includes, at least annual screening of your blood pressure and your lipid values in your blood. Testing for A1C in your blood, so that's a screen for diabetes that's often used. That one's recommended based on someone's risk. So it can be annual or every 3 years, depending on someone's perceived risk. Again, after the age of 40, that's a universal recommendation. But yeah, it's a gap, absolutely, in terms of, okay, providers maybe know that, but we know that often primary care providers are very overworked. They have, many patients they're following. And so it's one where, again, it's a system that's relying, as you said, relying on people kind of being the ones to initiate that for themselves, rather than having that invitation and knowing more information about, what they could be doing to be more on the preventative side for not only heart health, but, all routine health screening or prevention strategies. So that's one that I think we could do a lot better for in terms of, having that messaging be not only for care providers in their formal education, but for patients and people to know, again, what should I be aware of, right? So excellent point.
Thank you. More questions? Thank you very much for a
No,
great
thank you for having
presentation
me.
and great
Thanks
discussion.
so much.